Hi, everyone, and welcome to another episode of the Cycle podcast. I'm very excited today to have a very special guest, Dr. Fogelson. I'm sure you've heard of his name before if you're in the endometriosis community, and if you haven't, he is very outspoken on social media about endo, and I'm really excited to have him today. And with that, welcome.
Michelle, thank you so much for inviting me onto the podcast. We have our own little podcast as well at times, and although we don't publish it as often as we should, but it's great to be able to cross-pollinate onto other people's stuff as well, and I appreciate the offer.
Well, we're really excited. We have a pretty big listener base in the US, Canada, Australia, and some other countries as well. And typically on this podcast, honestly, is what we do is we share stories. So I interview a bunch of endo patients and they tell their stories, and everybody has a different story, as I'm sure you know. But it's nice to get your perspective, and I really appreciate how much you do on social media because I think it's really needed. And with that, tell us a little bit about yourself and how you got into working with endo patients.
Yeah, absolutely. So I'm Nicholas Fogelson, or known as Nick Fogelson to most of my colleagues, and I have a practice in Portland, Oregon. It's called Northwest Endometriosis and Pelvic Surgery. It's kind of the culmination of my clinical career in a way. I graduated from medical school in 2001, and then went on to do a residency in obstetrics and gynecology. And at that time, I was very interested in actually high-risk obstetrics and surgery as well, but I didn't really have a horizon for endometriosis per se. And I finished that residency, and I took a faculty position at the University of Hawaii, and I taught there for about 3 years, and did general obstetrics and gynecology, and did some surgery, but really wasn't a very well-trained surgeon at that time. And then went back to the mainland, actually back to South Carolina, to the University of South Carolina, and was teaching there. And I had kind of some interesting experiences. I had a few patients that had endometriosis, and I'll be honest, I had really no education about how to take care of them. The education that I had as a resident on how to deal with endometriosis was effectively put them on birth control pills. If that doesn't work, you can try Lupron. If that doesn't work, you can do laparoscopy, but that won't work. Probably won't do any good doing a laparoscopy because there's nothing really you're doing. You're just looking anyway. And then you can take out their uterus and ovaries, and that might work. If it doesn't work, well, at least they don't have any gynecologic organs left, and you can send them somewhere else. And as crazy as that is, people would say that. No, that's not what they say in a lecture, but that's what they say in the back room. When we're just casually talking about things, people say, well, at least if you take out your uterus and ovaries, she has no reason to see a gynecologist anymore. You can just ship her off to a pain management doctor or whatever. And so that as callous as that sounds is what people say. And
we feel it, and we know,
right. And that was my education at that time. We could go off into that, but just to kind of continue the original line, right. I saw a few endometriosis patients, and whatever I was doing wasn't working very well. Some people do get some improvement from medical therapy, but I was sort of aware there were certain doctors that were doing it differently. I had met a few who say they do excisional surgery, and they do, or they claim to have success with endometriosis patients. And I kind of, looked up a little bit of what they're doing. David Redwine was one of them. There were a number of other people. There was some European people. And I don't know, I was always kind of a glutton for punishment myself, as far as okay, what challenge can I overcome? This sounds challenging. Maybe I can get good at that. And also at the same time, you have a population of women who are just so incredibly afflicted with this awful condition. And it's pretty shitty to say, well, sucks to be you, there's nothing we can do. That's not a very, as a physician, it's not a very nice position to be in, to be kind of powerless to help people. You go into medicine, hopefully, because you want to help people. Right. And at the same time, it's frustrating too. It's almost emotionally frustrating. Physicians get kind of, that don't understand how to manage the disease state, get kind of burned out on it, because they're like, I don't know how to help you. I'm tired of sitting here and telling you I don't know how to help you. And so anyway, so I was aware that there were some people that were having success, but then I also became aware that, okay, why are they having success? And the answer is because they're using surgical techniques that I was never taught, and that, looked incredibly dangerous and shockingly complex to me at that time in my career. And then I said, well, what would I have to do in order to maybe start doing that myself? And I kind of, that was sort of the big, really early in like YouTube and stuff. You got to realize back then, it's really hard to learn surgical technique because you have to have a surgeon there that's going to teach it to you. And if there's no one there to teach it to you, then it's almost impossible. You can't read it out of a book, really,
right.
and then expect to replicate it. And these days, you can watch, hundreds of hours of surgical video of whatever you'd like. And to be completely honest, I've refined my techniques watching videos of other people operating, and other people, I'm sure, watch some of the stuff I publish and learn some things. And so, but back then it was impossible. Like if you didn't have somebody to mentor you and teach you these techniques, you just weren't going to learn them. Yeah. And if you were to kind of teach yourself, you probably leave some injured bodies in your wake while you
right.
teach yourself to do things that are sort of dangerous.
Right.
And to be honest, some of the pioneers in endometriosis surgery who were teaching themselves did leave some injured bodies in their wake,
right.
Unfortunately.
Yeah.
And so I said, I got to learn more. I decided to do a fellowship. My personal life situation had changed to where I could kind of reset my life at that point. And I went to Emory and I did a fellowship in the division of GYN oncology, actually at Emory University. And I basically did a year of cancer surgery fellowship, but I was very focused on learning the techniques of cancer surgery for the purpose of doing endometriosis surgery. I mean, that was always on my mind. And spending that year was just revelatory and transforming me as a surgeon, because I had been operating for 6 years and I'd kind of improved what I've learned in residency, but I kind of hit a wall, and that just sort of exploded through the wall and gave me the time to study anatomy, gave me the time to study technique, and really kind of open up to where I felt like, anything that I can't do at this point, at least I can learn. Like I wasn't really afraid to learn anything anymore. And at that point, the ability to watch other people operate on video was starting to come about. YouTube was starting to come about. And so, and more meetings and so forth. And it became easier to kind of cross-pollinate what people were doing. And then I sort of, at that point, stayed on at Emory, and I ran the minimally invasive surgery program for 3 years. And I was the only person in that department who technically was sort of a minimally invasive gynecologic surgeon, which is a made-up title anyway. But people ask me, what is that? I said, well, you just get good at laparoscopy and order some new jackets. So
you get some extra letters over here.
Yeah,
I appreciate the honesty.
Order some new jackets.
Right.
Of course, there's a fellowship now as well, but you can get good without doing that fellowship. But anyway, and then I did that for 3 years, and then my daughter was born, Azalea, who's now 6 years old, and my wife, who I married in Atlanta, we decided to move back to Oregon, where I grew up. Actually, I grew up in Eugene, Oregon, and I joined the Pearl Women's Center, which is a minimally invasive surgery practice in Portland, Oregon, with Richard Rosenfield, who's another gynecologic surgeon that does some work in endometriosis as well, but maybe not to the level that I do, or to the as much as cases as I do. And I worked with him for 3 years. That was great. And then I decided that I'm going to be 100% focused on endometriosis, and I left that practice and started my own practice. And so now I have my own practice. It's just called Nicholas Fogelson, MD, Northwest Endometriosis and Pelvic Surgery. And it's all I do. And what I've done is, by basically running my own show, nobody gets to tell me what to do. I spend as much time with my patients as I want. I mean, my new patient consults are an hour or more, sometimes 2 hours, because these complicated, there's so many limitations that physicians would have if they wanted to have a career specialized in endometriosis. I mean, let's just forget, do they have the surgical ability or knowledge or whatever? Forget that. If you work for a hospital system that says you have to see 27 patients in a day or 24 patients in a day, it's impossible to provide a good care to a patient with really complicated pelvic pain, because this stuff's complicated. It's hard to figure out. And if I see a new patient that has a complicated issue, we may talk for an hour, and then we may do an exam, and then we may talk for another half hour. It's like, how can you do that if you're expected to see 24 patients in a day? You can't. And so when I see a lot of people online, really kind of being critical of physicians who aren't as experienced in pelvic pain, part of me goes like, you don't understand, like the structure of the job that they have makes it entirely impossible that they would make a specialty out of pelvic pain. It's impossible. And so anyway, so that's the kind of practice that I've created, and I've really enjoyed it. My practice has grown in the last 18 months. It's been stable financially, and we're seeing lots of patients, and it's been good. I mean, I've really enjoyed it, and I've got Melissa as my assistant, and people that have called my office know her well, and she's been fantastic. So that's kind of how I got from graduating medical school to having my own practice specialized in endometriosis.
Well, that was actually very helpful, and even just a little bit of that behind the curtain, because something I try to tell people all the time, and I don't know anything about medical care, but people are so frustrated because they trust their OBs, or when they go there and they have these surgeries, and then they're frustrated that this person didn't know about endometriosis. And so it sounds like, I mean, clearly you're not educated deeply in that in medical school.
No, I mean, what you're taught in medical school, I mean, I would start out by saying nobody understands endometriosis. I mean,
True.
there are people that know more than others, because there's people that have read, I read every month, I probably read 10 or 20 journal articles of what are new ideas that are coming out in endometriosis, but I have yet to read the one that explains the disease to me completely.
Yeah.
So, I mean, somebody that is, quote, an expert in endometriosis probably sees a lot more endometriosis patients. And so because you see a lot of patients with pelvic pain and complex pelvic issues, you start to see the differences between people, and you start to see, okay, this patient kind of behaves this way, and they have this disease state, and this patient has this kind of, and I don't mean their behavior, but I mean the way their disease state behaves.
No, for sure.
And so as you get more experience, and you start having under your belt of experience of having seen hundreds of women with endometriosis, like that's what made you an expert. Like that experience is what's made you an expert. And it's not like you can read a book and then suddenly know everything about the disease, because there is no book that explains the disease, because we don't understand it.
Right.
That's not to say we don't understand anything about it, but I'm the first to say that it is not a medical condition that is understood to the level that many other medical conditions are. And I would challenge the people that out there, including many well-respected people who kind of claim to have it under a pin and that they know exactly what it is. I just don't think if that's true, why are we still having thousands and thousands of women who we can't entirely help? Like the most successful surgeries I do, take a patient who says I have 8 to 10 out of 10 pain, 7 out of 10 pain most of the time, and 10 out of 10 pain when it's the worst. And 6 months to 12 months later, she says, well, it's really only still hurts, but it's 3 out of 10 now. And I'm like, that's a success.
Yeah.
I can't take her and make her that she never had endometriosis.
Right.
But because we don't even understand what the disease is to some extent.
That makes complete sense. Yeah.
So I think that where we've gotten is we went to kind of the really basic that, okay, there's endometrial tissue growing outside the uterus, and it seems to be causing pain. Well, we know that endometrial tissue in the uterus will kind of calm down if you give it progesterone, which is true. It'll kind of thin it out. So if we do that, it'll thin out the stuff that's in the belly too, and that's going to make them better. And to that, and then, or we can try to operate and burn it away, and no one really, in kind of the basic level, people don't understand excision techniques very well. So now we've gotten to saying that, well, this tissue is not, it looks like endometrium. I mean, it's called endometriosis because under a microscope, it looks like endometrium, but it's not endometrium. I mean, it doesn't have the structure of endometrium. It has endometrial type glands and cells, but endometrium has a very specific structure that it lacks. Like it doesn't have this perfect lining of endometrium. It's a very disordered, invasive sort of, almost like if endometrium were a cancer, although of course there is an endometrial cancer, that's a real cancer, but if endometrium were just behaving in a very disordered way, it might look like endometriosis. But what we know is that endometriosis is actually genetically very distinct from normal endometrium, and that if you look at a given patient's endometrium and then you look at her endometriosis, it's not genetically the same. And I'm involved in research in that area now, and so we're just at the beginning of understanding the disease. I mean, I think you go back to scientists 500 years ago, who came up with ideas that were based on, the earliest light microscopes, and they decided that they knew what something was, but it was just based on such a superficial appearance of what something was, that it just wasn't really correct. And I think we're almost there in endometriosis, where, we're just getting away from realizing, well, it's not even endometrium. Like, someone gave it the name endometriosis, but it's not really, that's not what it is. We can't treat it like that. And so, now we have a sort of what we call the modern theory of endometriosis, which I'll still say is a well-supported theory, but I wouldn't call it the incontrovertible truth. But that modern theory is that endometriosis is probably a defect of embryogenesis, where during the formation of the Mullerian tracts, which are the female pelvic organs, excluding the very rare cases of endometriosis in men, which people like to say, what about this? It's like, okay, that's really rare, but let's talk about normal endometriosis. So as the female pelvic system develops, you have other areas in the pelvis that seem to get on these really early precursors of Mullerian structures. And then you have some very early hormone sensitive cells that are sitting there. And they're kind of like, I've said, they're kind of like sleeper cells of terrorist cells, that they're just waiting to come out and attack when someone tells them to. And when the woman goes through menarche around, 11 to 14 years old, and she starts to menstruate, then those cells start getting some estrogen impact. They get kind of, estrogen tends to tell endometriosis to grow, and it will, then that kind of wakes up, and then you get this period of every single month, these implants are becoming inflamed. The immune system is attacking them and trying to kind of attack the inflammation. And part of what the immune system does is it creates inflammation, and then it creates like scarring, like it kills off some things, and over time that creates scarring. And so over a period of 10 to 20 years, a woman can develop tremendous scarring in the pelvis that's really kind of like the bombing, like the bombed out city in Syria or something after there's been a war, that there, like, a conflict has happened here and there's a lot of damage left behind. Right. And that conflict was the immune system trying to deal with the endometriosis. And so there's, one theory of endometriosis is that we would treat the disease hormonally and try to just make it metabolically less active. And by doing that, the immune system doesn't have to try to fight it as hard, and so we're going to get less scarring. And that's a legitimate theory. I mean, there are definitely people that see benefit from hormonal suppression. And so I'm not one of these people that will tell you that, okay, medicine is bad, surgery is the only way to go. The reality is that there are a substantial number of women that benefit from medical therapy, and they do fine on it. And I think as an endometriosis surgeon, of course, the patients I see are the ones that didn't get better, because if they'd gotten better, their OBGYN put them on birth control pills, they got better, they don't seek me out. So it's easy as an endometriosis surgeon to say medical therapy doesn't work. But the reality is that there's plenty of women it does work for. It just doesn't, they don't end up in the surgeon's office as often.
I have a question on that. If you're taking birth control and you're suppressing everything, or the hormone therapy, and everything kind of calms down, but then it's still there, correct? Can it come back with the vengeance once you stop the therapy?
Yes. In fact, it almost always does. And so you're not making it go away. And so if you take it's generally the progesterone that is suppressing the endometriosis, if the endometriosis is of a particular subtype that is really progesterone sensitive, which is not all endometriosis. And you're not removing it. So when you go off of the hormones, it's going to come back. Right. And that's part of why people say that, there's the myth that pregnancy cures endometriosis. It doesn't, but pregnancy is a very high progesterone state. And so you're just awash with progesterone when you're pregnant. And progesterone is supporting gesterone is gestation. Is supporting gestation. Progesterone is the molecule that supports a pregnancy. And so you are awash with progesterone. You are heavily suppressing whatever endometriosis is there while you're pregnant. That's why people with endometriosis often say they felt great when they were pregnant. And then after they have a child, they're breastfeeding, or hopefully they are, but if they're breastfeeding, then they tend to have low estrogen levels, and that also helps to kind of keep endometriosis at bay a little bit. So you might have 18 months to 2 years with less symptoms, and then someone says, hey, pregnancy cures endometriosis. It's like, no, they are in a hormonal state that tends to support fewer endometriosis symptoms. Anyway, so we were talking about medical therapy. There's that side of it, but then there's the other side. If endometriosis was put there as a single genetic mistake during embryogenesis, can we just cut it out one time and then it won't come back? And it seems to be the case that for many people that is true. I never say anything's true for all endometriosis patients because I don't believe it's one disease. Like, I honestly don't believe endometriosis is one disease. I believe it is a syndrome of symptoms that is associated with a variety of different specific genetic diseases that we don't even know how to separate yet. But there are a large subset of women for which if you do, good quality excisional surgery, and you remove all endometriosis that you find, that they will not have endometriosis again. Which means if you were to go back and repeat a laparoscopy, you would not be able to find any tissue that comes out pathologically positive for endometriosis. So from one point of view, you could say that surgery cured them of endometriosis. I don't like to use that terminology because I think that women come to see me or to see any doctor because they have symptoms of endometriosis, and like the translation of their disease state is their symptoms. And to stand back and say, well, I cured you of endometriosis, and they say, well, but I still have these symptoms. Mm-hmm. And you say, well, you're cured of endometriosis anyway. It's like, well, who cares? Like, I don't care about the concept of curing someone with endometriosis. All I care about is how are their symptoms managed? Like, how's their quality of life? Like, that's what matters.
Yeah.
And so I don't find the terminology of being cured of endometriosis to be actually a useful terminology. And it's kind of confusing, I think.
I think so
too. So assuming that someone is trained in good surgical technique and you can really thoroughly remove endometriosis, then you can get good results with surgery for a lot of people. And I would never say that everyone responds exactly the same. And as surgical techniques have improved over time, and my own skills have gotten better and my understanding of certain anatomical kind of things have gotten better, you become more able to tackle even more difficult anatomical situations with endometriosis. Yeah. And have success with them. And so I don't know where we even got on that.
Well, I want to go back to hormone therapy. This is just an example and a question that I have, and we talk about on the podcast. So say someone was on birth control and they maybe had bowel disease. They have bowel endometriosis and they're taking birth control. They're suppressing everything. Is there potential still risk there? They may not know they have bowel endometriosis, but they have some of the symptoms. Birth control calms it down. Is it still risky in that type of case? I mean,
I think, first of all, the answer is, I'm such like a concrete person. My wife would say that the actual answer is, I don't know. No one knows the answer to that question.
Yeah.
But so then we kind of have an expert opinion. And so what's my expert opinion is that most people will not have, if they're having on medical therapy and it is suppressing their symptoms, it's probably suppressing the metabolic activity of endometriosis. That's why they're not having symptoms. So it's probably not progressing a lot on if they're having successful treatment. And I know there are people that say, well, it's still going to be getting worse. And it's like, nothing's true for everyone. There probably are people that have progression of disease despite being on medical therapy. But I think in general, if you're getting really good suppression of the disease, you probably aren't having that much progression. But that's just my opinion. It's very hard to prove it. Like, none of these things, there's so many questions in endometriosis that are impossible to answer because we don't have good animal models, and you can't just go operating on people every year for 10 years and document what happened,
Right.
It would be unethical. And so again, we have a lot of expert opinion. And so you have to kind of rationalize out what do we know about this disease state? What makes the most sense on what we can do? And so if you have a little bit of bowel endometriosis and you're getting better with medical therapy and your bowel function is okay, do you need surgery? Right. Well, if you want to get pregnant, you do, because every medical therapy in the world is contraceptive. And so you have a lot of women who have not completed childbearing and their symptoms are suppressed on hormonal therapy to a reasonable extent, but that freezes them in not getting pregnant.
Right.
Forget the fact that endometriosis has a negative impact on fertility, but the treatment that they're taking is a contraceptive treatment. I mean, they will not get pregnant while they're on it. And
Right.
so when you have women who want to have a baby and they have some bowel endometriosis and they have a bunch of endometriosis, if they just go off the birth control and try to get pregnant, they're definitely less likely to get pregnant than someone that didn't have that disease state. And those patients very well may want to have surgery to excise that disease, which is going to improve their likelihood of getting pregnant. And the evidence is pretty strong that resection of deep infiltrating endometriosis and probably even mild endometriosis will improve natural fertility rates. And it probably also improves IVF success rates, though that data is less strong and more controversial.
Yeah, I want to talk about IVF and hormones and all of that, but I want to go back because, like you said, you think there's different versions of endometriosis. I agree with that. I talk to hundreds of women all the time, and some have one excision surgery and they're fine. And they could have been stage 1, 2, 3, or 4, and their literally lives are totally changed. And maybe they have some pain here and there.
That's what keeps us going.
They're out there, I promise you. But then you have someone like me. I like to consider myself a difficult patient, right? I've had 6 surgeries. 3 of them were excision from top excision specialists. And I had full bowel obstruction in 2018 from endometriosis and had to have a bowel resection. And so I have a couple girls in my group that it feels like for some of us, it keeps coming back. Is there, I know some people have more aggressive disease. Does it come back or is it just left behind and it's missed? Because when you have an aggressive case, like I had to have a bowel resection. I know I still have disease because I still don't feel 100%, but I'm not upset about that because I had an emergency situation that needed to be surgically treated and 40 lesions removed in my last excision. But I had 2 excisions before that where I probably had 40 to 60 lesions removed. I mean, that's what I don't understand.
One thing I would start out is like the number of lesions is kind of it doesn't mean anything. I mean, there's only so much peritoneum in the pelvis that you can remove. Right. You know, there are certain surfaces in the pelvis that are peritoneum that can be removed, and then there's other peritoneum that can't be removed without removing the organ it's on.
Sure.
And so whether there was 5 lesions or 50 lesions on the pelvic sidewall, you're going to remove the entire pelvic sidewall, so you're removing it all. But I think that something is made, you know, whether or not there definitely is residual disease when people don't do good excision surgery. I mean, if you just go in and do ablation and the lesion is anything but like a really, really superficial lesion, it will still be there. I mean, you will not have removed it.
Right.
And you will be able to find pathologically, I mean, my definition of residual endometriosis is if I go in and cut it out and the pathologist says this is endometriosis, it was residual. Now, did it grow back versus was it left there? Who's to say? Certainly, you know, it helps the surgeon's ego to say that I don't know. Everyone wants to say that, you know, oh, that other surgeon wasn't good enough, and I'm a better surgeon, and oh, if you'd had me do it, it wouldn't be residual. It's all nonsense, you know. I mean, there's definitely, I mean, if you have excisional surgery by somebody who's not experienced with it, yes, they're probably going to leave disease behind.
Yeah.
But you can have surgery by the best surgeons in the world, and you can still potentially have endometriosis down the road. Now, did it regrow or was it left behind? Who's to say? How can you really prove that? Now, if it's right on the border of, if you can see the margin of what was cut out and now you see it growing right on the border, then you have a rational reason to say, well, maybe that it didn't look like endo when they chose that border where they're going to make their excision, and it turned out there was some lesions outside that really weren't apparent, and now they've kind of grown up. I mean, that's one way to think about it. Now, if you have regrowth of endometriosis, like smack in the dab, the middle where they excised before, did it regrow? Was it deeper than where they went before? Again, you don't know. Like, these are questions that I don't even find very useful to ask. Like, you just don't know the answer. You just try to do the best surgery we can. At the same time,
from the patient's point of view, though, like for us, we don't know. Yeah, I know you don't know, but like, there's so much uncertainty for us. Like, are we going to have another surgery if we feel pain? So like, we just live in this constant state of.
One thing I would say is that I would focus on quality of life. Don't focus on, do I have endometriosis coming back or not?
Right.
Or, you know, this constant idea of like, I would just say that not all recurrent pain is recurrent endometriosis, first of all. I mean, there's lots of people that you do a really thorough excision for and they're better for years. And down the road, they start having some pains again, and you just don't really know why. And you reoperate on those patients and you don't find endometriosis. And that's part of what drove me into neuropalveology, which we can talk about, is kind of like, will that intellectual thought process reveal the path to helping some of these people that we haven't helped yet? And so, you know, the frequency of recurrent pain is higher than the frequency of recurrent endometriosis. And
that's good fact to know. That's a great fact to know.
And if you have good excisional surgery, actual recurrence of endometriosis is not common. Like, if you go back and operate, you usually don't find endo unless there was something where the previous surgeon really just said, well, I don't know how to get that part of it because it's too technical, or I don't know how to do bowel work or whatever. But I think that the frequency of recurrent pain is going to be higher than the frequency of recurrent endometriosis. And it's for a variety of reasons. And we can be a lumper and a splitter. If you think of endometriosis as sort of a syndrome of dysfunction and pain, you can say, well, it is part of that syndrome that you have recurrent pain. If you think of endometriosis as just, do I have endometrial glands somewhere outside of my uterus, then maybe you don't. But if you have recurrent pain, well, who cares? So then the question is, are there other reasons for recurrent pain that are addressable? And, you know, I think that sort of neuromuscular issues, you know, anytime you have chronic inflammation, the muscles in the pelvis can get really tight, and pelvic floor physical therapy can be very helpful for people. I send all my patients for pelvic PT, ideally before and after surgery, but almost all of them go to PT after surgery. And again, that's not the silver bullet, but it will increase the number of people that have successful outcomes. Sometimes we use Botox in the pelvic floor. Sometimes we use neuromodulatory drugs. And I encourage most patients to do all of it. You know, let's excise the endometriosis. Let's get a really healthy diet. Try to have an anti-inflammatory diet. Let's try to reduce the kind of exposures to things that may be bad for endometriosis. And I generally just, you know, try to eat. Unfortunately, there's like a lot of environmental sort of hormone modulators that can impact pelvic pain and endometriosis, and they're in like plastics and a lot of the things that we use every day. And so you try to, you know, limit those kinds of things, try to limit, you know, certain kinds of, like a lot of mainstream skin products have a lot of hormone modulators in them.
Yes.
There are certain, you know, things you can do to try to avoid that. But it's difficult. It's difficult, especially when it's fairly ephemeral what these things are.
Yeah.
But anyway, so you try to have a healthy diet, try to frequent exercise is very helpful. Anybody that exercises regularly is going to have less pain than someone that doesn't. And so I encourage my patients that say, I have too much pain to exercise. I said, well, part of why you have pain is because you're not fit. It's like, actually, you may feel better if you exercise.
Yeah.
But
plus you could just get really stiff. And if you're in pain and stiff, when you start, even if you walk, it helps.
Yeah, no, it just helps. It helps your psyche too. And so you got to put all those things together, and you know, again, you got to think about if you really have a chronic inflammatory condition in the pelvis and we treat it successfully surgically, and you get from being miserable 20 days a month, and now 2 days a month, you're kind of miserable. That's a success.
I agree.
You know, and I think that if patients get completely caught up, or women get completely caught up in those 2 days and say like, oh my God, I still have endometriosis. You got to look at it globally and say like, what's the quality of life globally? Like, is it better? And if so, then hopefully we've done something useful. If it's not better, then maybe we haven't done something useful. And those cases are hard for the patient and hard for me too. I mean, it's not like this disease state is not like appendicitis. You know, if someone has an appendicitis, cut out the appendix, they're not going to die, and it's going to be behind them and within a month, that it will not affect their life whatsoever.
Yeah.
You know, and there's nothing very complicated about how you treat it either. It's very straightforward. Whereas endometriosis is a complex disease state that we don't entirely understand, and we don't even know why certain patients respond so beautifully to surgery and others don't. We don't know why some patients can have terrible endometriosis and not have pain. You know, there are people that have stage 4 endometriosis and they don't have pain, and it's like, Should they have surgery? I don't think so. I mean, I think that all I can do is
unless
make you, it's
they,
like,
they want to
maybe
get
I'm
pregnant.
preventing, right? Right. They're not fertile, then that's a reason. But people ask, should we prevent some terrible outcome down the road by operating now? And it's sort of like, well, I
I
don't
don't know.
know.
Yeah.
If we create pain after, I mean, obviously surgery is going to be painful. And if you have no pain, all I can do is make you worse,
Yeah.
And
There's
so,
risks.
right,
All those nerves, which I want to talk about.
right. And so I think a lot of people people talk about nerve damage from endometriosis surgery. And is that what's causing my pain? And I think it's not that common that people literally do nerve damage. And by I mean like literally cutting through nerves that were supposed to be remaining intact. I think that's actually pretty uncommon. There's very few surgeons that are even getting that deep to where they would really be getting to where they could do that. But I do think that when someone has been in pain for a long, long time, and then you remove the thing that hurt, usually what happens is they wake up from surgery and said you made them better because they don't have pain anymore. But then 3 months later, they start being in pain again, or 2 months later, and they want to get back to where they were. And the right answer is usually to wait another 6 months to a year. Because what happens is if you have nerves that are chronically inflamed from endometriosis, it doesn't necessarily mean the endo is right on the nerve, but kind of in the general vicinity.
Sure.
If you kind of manipulate around that nerve by doing surgery, you get what's called neuropraxia, where the nerves actually get paralyzed for a while. And that's that immediately woke up from surgery and you cured me, doctor. And if all we ever did was talk to patients 1 to 2 weeks after surgery, we'd have a 100% success rate, or a very high success rate.
That's true.
But a lot of times, once that kind of nerve starts to wake up a little bit, it wakes up and it's angry. And you get burning pain, you get sharp shooting electrical pains, if they're visceral nerves, you might get really dull backache and this sort of dull aching, because that's how you feel visceral pain. The sharp shooting pains are somatic nerves, and the visceral pains are these really dull aching kind of pain, or the visceral nerves. And so those nerves now become very, very inflamed, and those symptoms that were gone now have come back with a vengeance. And now we have to get down to some period where finally all that inflammation's gone down and the nerve function kind of improved. And that's why we got to bridge through that period with neuromodulatory drugs, maybe acupuncture, PT, anything we can do to kind of make life tolerable. And hopefully we're going to get to, 9 months to a year out from surgery and be better than we were before. And the worst thing we can do is go in that 4 and 5 month period when someone says, I was feeling so good and now I'm in pain again and my endometriosis is back. Like, no, that's BS. You're actually in a totally normal neurologic place where you had neuropraxia and now you have neurohypersensitivity, and you don't know yet what's happened with the surgery. It's a long process,
It's a
and
long recovery.
the worst thing you can do is go back at 6 months and thinking that something's coming back and try to do it again. That it's not. I think that's very destructive, actually. And these people they said they've had 20 surgeries in their life and they're 35 years old. You're like, well, what is that? I mean, how often can you operate on someone? And so I think that they're having these short periods of neuropraxia that they feel better, and then they're chasing after that, and they're never really allowing themselves to really heal from anything. And there are doctors complicit in that who are doing it. I mean, I don't operate on everybody that wants me to operate on them. I operate on people that I think I can help.
Yeah, absolutely. I think that's a really good point that's not understood very well in the endometriosis community too. I think immediately the thought is to trigger that something is wrong, the endo is back, and it's immediate. And I know after my last surgery, I felt that way too. But then after 8 months, I really started to feel good, really good. And I knew like all of the nerves and everything had calmed down. But I also added in acupuncture and meditation and things to actually calm my central nervous system too.
Which are real things. That is not, juju. That is, acupuncture is real measurable effect on the nervous system. I don't know how it works, but I mean, it is, you kind of know how it works to some extent. Like there's some things that make sense, but it really does something. I mean, it's helping. And neuromodulatory drugs like gabapentin and Lyrica. Like, I don't like this idea that I see in the online community sometimes that sort of says that all medications are bad, including sort of adjunctive medications like Lyrica and so forth. Like, the perception is your doctor's just blowing you off and they're putting you on this drug and they don't really want to treat me. Like,
right.
No, well, any particular doctor that may be true, but
Sure.
if I want to put people on that medication after surgery because I know that neurologically they're going to start waking up. Their nerves are going to start waking up in pain, and we want to shut that down and get them through that period where they're feeling bad, and hopefully get them to a period where they're feeling better. And one of the things that's really hard is that because there are relatively few surgeons who are really good at endometriosis surgery, and it's really growing though. I mean, I used to say that, but I mean, it's really, there's a lot of people now. I think YouTube has honestly like totally changed surgical training. But nonetheless, if people are kind of like traveling far and wide to get surgery, it's hard for that person to be your doctor. It's like if a patient comes to see me from Iowa or something, I may do a very good surgery for them, but I can't really be their doctor because I can't see them over and over, and I can call them. We can talk on the phone a little bit, but they kind of have to get local people that actually know what they're doing also.
Yeah.
And so I think of the process of recovering from major endometriosis surgery as being 6 months to 2 years of kind of things getting slowly up and down and hopefully kind of getting towards being better. But there may be ups and downs, and
Sure.
trying to guide a patient in that path is hard to do if all they do is they fly from 3 states away to have surgery and then go home.
But what's difficult about that from like patient's point of view, we only have one doctor in Michigan we just got last year that knows how to do excision in the whole state.
Right. Who's that?
Hinkner, Dr. Hinkner.
Okay. Yeah, I think that there's something like 38 AAGL fellowships now, and I'd say probably a good 2/3 of them train people in excision. So it's
good.
They don't all, and nobody comes out of those fellowships ready to tackle a stage 4 case by themselves.
Right.
But people go from not doing excision at all to being able to handle like a typical excision case pretty well. And I think that people accept excision now because I think that there's sort of a critical mass of doctors that say that, yes, this is probably the way we should treat the disease surgically, not under so much skepticism as it used to be. ACOG is still a little skeptical, but, AAGL, which is the, minimally invasive surgery world, if you go to the AAGL meeting, every single video on endometriosis surgery is excisional. Like, no one is talking about doing ablational surgery.
That's good.
And honestly, if you go to those meetings, you're going to see the most wild, hairy, crazy surgeries you'll ever see. It's like no one wants to show the video of some basic
of course.
thing. They're going to show some video of some ridiculous thing that they did.
Of course.
But and hopefully it benefited the patient. I mean, that's the whole reason. But I mean, you can't walk away from the AAGL meeting, which is the meeting of probably the best gynecologic surgeons in the world that happen once a year, and then go, nobody's doing endometriosis surgery. I mean, you had 6,000 people there, and probably 5 or 6, maybe 600 of them are like seriously in endometriosis, and other ones are sort of in endometriosis. So, and we start seeing a lot of people, you realize you're not alone.
Yeah.
And any one surgeon that, claims to be the only one isn't paying attention. I mean, there's a lot of surgeons out there that are doing a good job.
I think it's improved immensely in the past 10 years. I mean, compared to 10 years ago, there were not that many people, at least in the US, doing this type of surgery.
Right. And I think that we just kind of hit a critical mass of people in the AGL. I do think that YouTube has changed things. I think you can watch other people operate, and you can learn from the best people in the world who are publishing their work. And people joke when you say that I learned this on YouTube, but I'm serious. Like, you can watch, I can watch Mark Passover do neurodissections and learn from them. I can't go to Switzerland and spend a year with him very easily, but I can watch surgeries he's done. And, and I've achieved a point in my surgical education where I can watch something and pretty reliably replicate what's happening, pretty well. And so, because surgeons can so easily watch each other operate, and we collaborate online and so forth, I think so many more people are kind of learning these techniques. But you still have the problem of if you want to focus your career in endometriosis, you better find a very particular business structure that's going to allow you to do it, because the insurance companies won't pay you very well to do it. They will pay the hospitals well for the facility fees for your surgery. So if you work for the hospital may subsidize you to be paid a reasonably good salary because you bring so many surgeries to their operating room. But if all you're doing is getting paid for the professional work you're doing, you can't have a career doing endometriosis surgery unless you choose to work outside the insurance systems, which a number of surgeons have done.
Right. And that's good feedback for patients to understand as well, because that's the
right.
behind the curtain stuff that we don't see and we don't understand.
Right. And it's not a matter of, when you see a surgeon that's charging some amount of money for surgery, at some level above some bar, it starts to become kind of crazy numbers that I think is just kind of bizarre greed. But I think at the relatively low numbers, what I think I charge in my office, I charge $4,000 or $5,000 for my sort of surgical fees, which it's not nothing, but it's not exorbitant. Sometimes I go a little higher than that, but that means that I can practice and do endometriosis surgery all the time. I can do what I'm passionate about. I can focus on continuing to learn, traveling, meeting with other surgeons, and doing what I can do to be the best doctor I can. Like, I can't do that if I get paid by the insurance company like $900 for a 4-hour surgery. That I can't build a practice doing that. Right. And so that's the reality. So a lot of surgeons have the technical ability for surgeons to learn how to do these surgeries is much, much better, but the medical economic structure doesn't support an endometriosis practice except for certain ways of doing it.
That makes a lot of sense. Well, I want to get into the unique, you talked about Dr. Passover, which I saw him at the medical conference a couple of years ago in New York, and was just like, after his presentation, my jaw was on the floor because it was just there's just so much interesting things that he's working on. And I feel like you're one of the only people we have in the US that actually works on neuropathology. How do you say it?
Neuropelviology.
Pelviology.
Right, which is the term Mark made up, which is fine, which is good.
Which I can't even get out of my mouth. But will you tell everyone who's listening or watching, what does that mean?
So neuropelviology is a field that it's kind of a condensation of the life's work of Mark Passover, who was sort of the first neuropelviologist. Still practices in Zurich, Switzerland. And I think what Dr. Passover has done is he's taken everything that every doctor learned when they were a second-year medical student, and we all did neuroanatomy and neurophysiology and neuroanatomy, and we crammed it all into our brain until we could get an A on our test, and then we immediately jettisoned it so that we could fill our brain with something else. And that wash and repeat in medical school times 15 until you actually go to residency and actually learn something you're going to remember. And so I always say that medical school teaches you doctorhood. It doesn't teach you medicine. Right. You learn medicine as a resident.
Yeah, hands-on.
You're indoctrinated into doctorhood as a medical student. So Mark took what we already kind of understand about neurophysiology, but by and large, gynecologists have completely forgotten this stuff, and they haven't ever really applied it to why do women have pelvic pain. And when women have pelvic pain, what is going on? And you get away from this simplistic idea that I have pain here, so I must have a problem here, so I'm going to operate here. If you really understand how the pelvic nervous system works, that's wrong. It's just wrong. And it's wrong because that's not how the body feels pain. I mean, if anyone has hit their funny bone and they felt an electrical shock run up their arm into their shoulder, did anyone ever occur to them there's something wrong with their shoulder?
Right.
No. Right. Why did their shoulder hurt? Their shoulder hurt because they compressed their ulnar nerve, and the nerve got a jolt that just ran all the way up into the spinal cord. But in the pelvis, I think that someone says, well, I have pain on the right side. And someone says, well, let's take out your right ovary. But it doesn't have to be the ovary. Like it could be, it might be, but
sure.
If you really get into first we differentiate what is a somatic pain versus what is a visceral pain. And that means somatic pains are getting cut with a knife on my skin is a somatic pain. I know, I feel the pain exactly where the injury occurs. my brain is able to localize that pain exactly. And furthermore, if you were to create a sensation along a somatic nerve, if you were to create an injury along a somatic nerve, typically, like the skin itself, we're able to track exactly where the injury occurs. But if you injure a nerve, like we said, like the ulnar nerve, when you hit your funny bone, that's a somatic nerve. You feel pain along the entire pathway of that nerve. Not only did it go up your spinal cord, but it probably went down into your pinky too, right? And your pinky wasn't injured either, because these two fingers and this side of my hand is innervated by my ulnar nerve. So basically, all of that area, I got some lancing pain going up my neck, all the way into my neck, and that's just because the nerve got banged. So, what if the nerve that is terminating in a certain area that is causing pain, that where you feel the pain, that the injury is actually somewhere up higher on the nerve? It's not where I'm feeling the pain. And so a really classic idea of this is sciatica. Like, a lot of people feel sciatica even if they don't have endometriosis, and they have a pain that's running down their leg. It's maybe going to the bottom of their foot, down the back of their leg. No one has ever said, "Oh, there must be something wrong with your leg. Let's operate on your leg." It's like, no, and yet it's your sciatic nerve. The sciatic nerve is innervating those areas, and the sciatic nerve is irritated. And so in somatic pains, you have a nerve that is irritated, and you're feeling pain generally along the terminal pathway of that nerve. Now, visceral pains are different. So visceral pains are dull, aching pains that you can't localize them. You can sort of, like, if a patient tells me the pain is here, it's somatic. If she goes, it's here, well, it's probably visceral. So, and these dull, aching pains are visceral pains. They're carried through different nerves. They don't come through the somatic nerves. They come through the visceral nerves, usually the sympathetic chain, there's plexuses of where sympathetic and parasympathetic nerves join together. And within these plexuses are generally where these dull pains are felt. And there's about 7 of these different plexuses in the body. And generally with visceral pains, rather than feeling the pain along the entire length of the nerve and potentially at the terminal branch of the nerve, you actually feel pain at the first plexus where that signal gets to. And so the first plexus that pelvic pain may get to is the inferior hypogastric plexus, which is going to radiate pain into the back of the sacrum and the back. And that's what's picking up visceral sensation from the uterus and the bladder and the end of the rectum. And so, if people have this really dull, aching back pain, I can tell you what's happening is their visceral nerves are getting sensations from either the rectum or the bladder or the uterus, or even the nerves that used to go to the uterus even after hysterectomy. And it's sending that signal. And if that signal is strong enough, it can even travel all the way up, and they can feel chest pain. They can feel upper abdominal pain. They can feel even pain in their neck and chest. And they may feel visceral symptoms, like they may have dilated pupils. They may feel sweaty. They may feel, I think that POTS, postural orthostatic hypotension syndrome, I think that is a sort of a autonomic dysautonomia that possibly is from disordered visceral nerves. So people may have those kinds of symptoms. I mean, I definitely see kind of an overrepresentation of people that have been diagnosed with POTS in the endometriosis world. And I think that they have visceral dysautonomia from their endometriosis, and that someone has given them the diagnosis of POTS, which again is a syndrome. The S is a syndrome. And for people that don't know, syndromes are not diseases. Syndromes are constellations of symptoms that tend to go together, that physicians have noticed go together enough to give it a name. And so that's what a syndrome is. And if we're lucky, they didn't name it with their own name and call it, like Peyronie's syndrome, which is a penis that points sideways. So what neuropelviology does, just at a basic idea, is let's take this real understanding of, like, okay, what's the difference in a visceral and somatic pain? Why would you get neuropraxia? Like what I was talking about, how a nerve gets initial neuropraxia and then it gets hypersensitive and then it gets calmed down later. I mean, that's neuropelviology. Like, I don't hear other endometriosis doctors talking about that too much. No, that's kind of what I learned when I studied more neuro stuff. And so it gives me a certain amount of comfort when a patient who was better after surgery is in pain again 4 or 5 months later, and I go, oh my gosh, maybe I didn't do the surgery well enough. Like, no, actually neurologically, this is what should be happening. And it helps the patient to tell them ahead of time, this is what's going to happen. And you don't need to freak out. you can expect when the patient says, "Oh my God, I feel so much better." I said, "Great. You know what that means? That means we were in the right place."
Right.
You know, all that means is that I was operating close enough to the nerves that were hurting you, that those nerves are now neuropraxic and they're not sending signals to your brain.
But they're going to in about 4 to 5 months.
Or maybe sooner. And I worry more about the patient that they wake up and they're not better at all. Because then I go, I probably wasn't operating where your pain was happening.
Right.
And so if the pain goes completely away, I tell my patients, great, we were operating in the right place, but please understand you're probably going to be in pain again at some point soon.
Yeah.
Some point. And but the fact that we were in the right place means there was a good chance that over the long run we did something that will help you. So that's sort of just one concept of neuropelviology. And I studied, Passover basically created an educational program that is a formalized educational program where it put together a whole lot of readings and a bunch of lectures. And that's sort of the first didactic portion of it that I sort of felt forms the intellectual foundation of neuropelviology. And that process I've gone through, and I've become certified in that level 1 certification in neuropelviology. And I think there's just a handful of people in the United States that have, maybe even only 2, last I heard, but there may be more since then. And then there is another level of neuropelviology certification where is actually didactic training with Mark and some of the other sort of leaders in the ISON, which is the International Society of Neuropelviology. And we go and we do neuropelviologic surgery on cadavers, on dead bodies, and refine some of the surgical techniques. And I keep wanting to do that, but it keeps getting canceled because of COVID, because of this, because of that. So now I was going to be doing it in like March, and then I was going to be doing it in June, and now I'm going to be doing it in November. And so assuming COVID is
hopefully,
down enough.
Yeah.
And so, but to some extent, like that part of it, like the surgical technique can some extent be learned by watching video of other people doing those surgeries, as long as you have the requisite understanding of anatomy to translate that into actually going and doing it. And that's kind of where I am. Like, I think that the intellectual part of it, I've, definitely learned some things. I'm sure that we'll continue to learn.
Sure.
I've learned enough to pass whatever exams they required of me, and which are really quite hard, actually. The exams are kind of brutal, but and then the surgical part of it is just a refinement of understanding the approaches to how to get down to some of these nerves, because even the really well-known endometriosis surgeons are usually not operating down onto the pelvic nerves. It's like a whole nother level of depth of where you're going. And it's not that you couldn't. I mean, you just have to understand how to safely approach those spaces. And it's kind of like the "Here There Be Dragons" when you're going off the edge of the flat earth on the map, is that you're going down into an area where there are very, very big veins and blood vessels, and any kind of mistakes in those areas could be pretty catastrophic.
Yeah.
And then, of course, if you're operating right on major nerves, on sacral nerve roots and on the sciatic nerve and so forth, and I don't mean operating on the nerve like cutting the nerve around, but trying to move endometriosis around there, you can cause significant
damage.
You can potentially cause injury. I mean, obviously, if you say you cut someone's sciatic nerve, they would never walk again.
Right.
No, they wouldn't walk right anyway.
Yeah.
They could walk sort of, but so to some extent, we have to separate our excitement as surgeons that, like, oh wow, that's a really cool technique, I want to go try to do that, to really, really understanding, okay, who should we operate on? Which of these patients made these techniques actually benefit? And then we got to say, okay, now we got to train ourselves really well so that we can actually replicate these techniques and not hurt people and help people.
Right.
Because you can, and I'm very, very conservative myself about what cases do I want to really operate on in a neuropelviologic type of style, because I don't want to treat the patient like a cadaver. I'm not operating for my own entertainment. I'm operating because I think I can help them.
Yeah.
And so, again, we're kind of into an area where there's not that much education out there to be gleaned on. So you have to work on it. And I do pudendal nerve decompression surgeries now, which I kind of have done enough of that I feel pretty good about that technique.
What about the hypogastric plexus nerve? I had a girl reach out to me and say that she had an endo lesion on that nerve.
Yeah. No, a lot of people do. If you have a big lesion on the uterosacral ligament, it's going to be impacting that nerve. And that's a plexus of nerves. It's a visceral plexus. So the plexuses are where visceral and somatic nerves come together, and where parasympathetic and sympathetic nerves come together. For your listeners, or for you, may not know the difference. All the sympathetic nerves are kind of the fight or flight, rev you up nerves, and the parasympathetic nerves are kind of the opposite nerves that kind of slow things down. Things like making your gut digest, making your bladder empty. Obviously, if you're running from the saber-toothed tiger, you don't want to pee. So sympathetic holds your pee in, parasympathetic lets the pee out. And sympathetic shunts the blood away from your gut because you're not worried about eating when you're running from the saber-toothed tiger. Parasympathetic makes your bowels work better. And so these are, sympathetic gives you an erection, parasympathetic gives you an orgasm. So it's like these things go together.
Yeah.
And so they're kind of like opposites to some extent. But so the hypogastric plexus is you have a big branch of sympathetics coming down right the center, right over the top of the aorta. And then they split into two branches, and those are the superior hypogastric nerves. They go right lateral to and deep to the uterosacral ligaments. They start out actually a little bit inside of the uterosacral ligaments, and they end up going to the outside of the uterosacral ligament, kind of under the ligament. And in the beginning, those are just sympathetics, and so they're just carrying sensation from the rectum and the bladder and the uterus. And have you ever heard of a presacral neurectomy procedure?
Mm-mm.
Oh, you haven't? So that's a procedure where you actually cut the sympathetics that give you sensation from the bladder and the uterus. So some people do that procedure to decrease uterine pain. So so those nerves up high are just carrying sensation from the lower pelvis. And then as they get lower, they start picking up parasympathetics from the nerve roots, and that's where giving you bladder function, it's giving you bowel function, and some of the uterine function as well. And so that nerve that you're talking about is generally what they're talking about is actually the plexus where those things are coming together.
Okay.
And if you have pain there, you're going to have dull aching pain in your back. If you have disease there, you may have bladder dysfunction. So if somebody says, I have really spastic bladder all the time, I can't hold my urine for more than 5 minutes, a lot of them get the label of interstitial cystitis, but I think that a significant number of people with interstitial cystitis actually have endometriosis that is on the visceral nerves to the bladder. And the issue is not the bladder itself, the issue is the innervation of the bladder.
I agree. I'm not a doctor, but I agree with that because a lot of women have it just with their cycle. Like they will only have bladder dysfunction during either ovulation or menstruation.
And they may have endometriosis that's kind of near those nerves. And again, interstitial cystitis is a syndrome. It is a syndrome. People even call it painful bladder syndrome. We got to realize that anything that's a syndrome is not one monolithic disease, meaning that just because everybody can fit into this bucket that we've called interstitial cystitis, not everybody, but a large number of women, doesn't mean they all have the same fundamental pathology that's causing those symptoms. And I would argue that endometriosis, again, is a symptom, is a syndrome. And they, why is it that the person that has a couple spots of endometriosis on the pelvic sidewall who has a lot of pain, and then the other one who has horrible disease, but she doesn't have any pain, to the one that has terrible stage 4 disease and horrible pain, it's like, why are these like the same disease, or are they not? It's like they seem pretty different. And people want to say, well, it's a progression. It's like stage 1 cancer, stage 2 cancer, stage 3 cancer. But I would tell you that even that is a confusion. Like people that have stage 1 non-aggressive cancers may never have advanced cancer. That actually these really advanced cancers are often genetically distinct from these really early slow growing tumors. And in the same thing, I think these really advanced cases of endometriosis are genetically distinct from the person that has some mild amount of disease that you put them under control and they're fine.
Right.
And so that's part of why I discourage a little bit in the online community from people kind of declaring what is the truth of this disease, that these doctors are idiots, these doctors are geniuses. And I'm like, nobody really understands it that well. So I'm not sure why. There are people that read more about it than others, but I think that nobody, if anybody really solves this, they're going to win the Nobel Prize. Okay. I mean, it's not solved yet.
I hope they do soon.
Yeah. Well, so anyway, back to neuropelviology a little bit, and
Yeah.
I'll tell you a little bit about maybe what we can get to where we can understand the disease better. Is that so neuropelviology allows us to do some additional surgical techniques. I'm kind of more involved with some people that have pudendal neuralgia than I used to be, which isn't really endometriosis, but it's a chronic inflammation of the pudendal nerve, and they're getting pain in their anus and in their perineum, and they may get pain in their clitoris and vagina. Some people feel like they have a mass in their vagina. Some people feel aroused all the time. These are all symptoms of pudendal neuralgia, and men have pudendal neuralgia also. And so basically, there are a variety of reasons why that nerve can be irritated. It can be irritated by endometriosis, but it can also be compressed in the same way that someone could have carpal tunnel syndrome, compressing their median nerve. And there are certain population of patients that can benefit from surgical techniques that kind of decompress the nerve, where we open up the canal that it goes through. So it, just like someone would do a carpal tunnel release, which is a fairly well accepted surgery for carpal tunnel syndrome. Certain kinds of pudendal neuralgia can be improved by basically doing a carpal tunnel release, but it's down at the bottom of the pelvis. It's a different tunnel.
Yeah.
And it's technically kind of a challenging surgery, but as you start to learn, the neuropelviology approaches to things, you can get down to there and you can do that. Just like all other neuropelviologic things, the secret to that is not learning how to do the surgery. The secret is learning which patient to do the surgery on.
Yeah.
Because if you do it on the right patient, then you'll probably make them better. If you do it on the wrong patient, they won't be better. They'll probably be worse. And they didn't need what you were going to do. It's not that the surgery failed; it's that the surgery wasn't ever going to work because it wasn't the right patient to do it on.
Yeah.
And so figuring out who are these patients that might benefit from these kind of, whether it be nerve decompression or whether it might be that they have vascular compression of their sciatic nerve or they have vascular compression of the sacral nerve root. How do you figure these patients out? And I think Mark is 20 years ahead of me as far as having that clinical judgment. And I'm just still growing that and starting to offer it more and more in what I do. But we also, have to be careful that we don't, and even, we don't hurt people. And even at the International Society of Neuropelviology meeting, we had a couple of pretty experienced surgeons standing up and saying, don't try this at home. That sort of like, that we don't want to get into a world where people think, well, everyone's going to just start dissecting down to sacral nerve roots and think they're helping their patients, because you got to really understand which patient actually is likely to have that problem, because unfortunately, like, there's hardly any imaging techniques that are really going to reliably tell you ahead of time. And I'm do not claim total mastery of this. Obviously, I guess I have a little more, I guess I have more education than most, but nonetheless, like all things in endometriosis and pelvic pain, it's not absolutely understood.
Well, this is all really, really helpful information. Any other advice for endo patients or people who might be just starting out on the journey? We have a lot of younger people in the early 20s who have pelvic pain or just got diagnosed. They're not really sure what to do next. And then we have other people who've maybe had one surgery, like an ablation procedure, and just kind of feel a little lost.
Well, I mean, I think I think that if you are seeing your general OBGYN and they're not, what they're offering you is not really led to you getting better, definitely consider seeing someone who makes a little bit more of a career out of really dealing with a lot of pelvic pain and endometriosis. Mm-hmm. Additional surgery may be appropriate for you. It may not be, or it may not be what you want to do right now. Excisional surgery is definitely the best technique that we have surgically. If you can get better without surgery, whether it be PT or medical therapies, and you can have a good quality of life, then go on having a good quality of life. I mean, this may be in disagreement with some other people, but I do not encourage people who don't feel like they have a problem into suddenly problemifying their non-problem.
Yeah.
If they don't have much, if they have some endometriosis, but you don't really feel like it's impacting your quality of life very much, don't let Facebook convince you that you have something worse than you have, because you don't have a very bad case, obviously. Doesn't
Right.
mean that you don't have you could physically have significant amount of endometriosis, but if you don't have symptoms, you don't have symptoms. So
Right.
Don't assume everyone else's experience is your experience. Use online resources as a tool, but recognize that it's a very selected population. People that have mild endometriosis symptoms do not spend their life on endometriosis advocacy Facebook groups.
No, they
People who get much better from surgery probably hang out for a while, but after a while they get on with their life and they kind of exit the advocacy world.
Yes.
Not necessarily the advocacy world, but they exit like spending all their time on Nancy's Nook and stuff like that. And so I think that the population of people who are the regulars online are a greater number of people who are struggling with the disease than necessarily the entire population.
100% agree.
And so I think you gotta, and the other thing I would tell you is you can educate yourself a lot online, but don't discount the education and experience of your physician. Even if your physician is not an endometriosis quote expert, they still know more about a lot of things than your non-physician does. Yeah. And in the areas of endometriosis, you're going to be bringing some things to the table if you talk about excisional surgery that they don't know about, but you can't twist their arm into doing a surgery they don't know how to do. Yeah. So you don't have, there's no reason to be angry at people that, there's no reason to be angry at me for not knowing how to treat a brain tumor. And there's no reason to be angry at your general OB-GYN for not knowing how to excise endometriosis. Like that just not, they're not trained to do it.
Right.
So once you decide that you want to see someone who's a sort of an expert in this stuff, I would encourage you to, I tell everybody to find a doctor that you trust and then trust them. Mm-hmm. Which means find someone that you feel like is listening to you and giving you the kind of feedback that you need and information that you want. And then maybe take a little bit more of a back seat and let them give you some advice and see if it sounds reasonable enough that you want to take it. Yeah. I think that sometimes when people are feeling like they're not being heard and they're not working with someone who's knowledgeable and they feel like they have to take control of the reins so much, and then they have a hard time letting go of the reins. And it's sort of like, okay, at some point you have to trust the people that have studied this a lot, and what can we do the best that can try to help you. And I feel a little bit that there's a sort of I'm like tortured by ethical concerns all the time, because I'm just bizarre that way. But there's a little bit of a weird, when you're a physician that has focused on endometriosis, and because of the business financial realities of it, you've chosen to go outside the insurance system. And so now you are asking someone to trust you to tell them to do something that in turn they're going to pay you to do. And so,
true.
And so, to some extent, you want to really make sure patients understand what it is that we're recommending, but at the same time to understand that we think it will help, but we don't think nothing is an absolute panacea. And I can't, for any amount of expertise and for any amount of money, I can't turn someone who had endometriosis into someone who never had endometriosis. Yeah. I can make things, and many people I can make things better. But just to get, if you don't notice, I get off on the sides a lot. That's the way my brain works. But
I think it's a surgeon thing.
Yeah, but I think that it's helpful to find somebody that you feel like you connect with and that you trust, and then really kind of try to take their advice. And if they give you advice that is contrary to something you read online, listen to your doctor. Look, to some extent, listen to your doctor over Facebook, because Facebook is giving you a lot of real generalities. And I think that people want to present monolithic truths, but like we said, the disease is not only one thing. And your doctor has the experience of having seen hundreds of patients with the condition that you have, and may see how you differ from someone else, and may be able to make a recommendation that isn't quite what the monolithic truth told you is the right thing, but may actually be right for you. And if you do see some sort of contrast between what you're reading one place and what your doctor's telling you, ask them. You can ask them, say, well, yeah, why do you recommend this for me? Don't assume that they're immediately wrong because it wasn't what you read online, but rather, why do you recommend this for me? And if they give you a really thoughtful, educated answer, then they're probably right. You know, if they tell you, well, that's what I do in all my patients, well, then they're probably not really that thoughtful about endometriosis. So,
well, here's the tough question that I want to ask then. So if someone asks their doctor and they say, we need to just keep doing ablation surgeries or ablation on you, should that patient continue to go to that? This is
because
where
they're not getting better, right?
right.
Yeah, they're not getting better. I mean, why do the same thing over and over if it's not working?
If you had a choice, like if someone listening to this right now had a choice to either get excision or ablation, what should they do?
You should, if you're going to have surgery for endometriosis, I think you should have excisional surgery.
Yeah.
I don't think ablational surgery, I don't really mean, you know, when I said those words, I don't really mean that you should have surgery by people that aren't experienced endometriosis surgeons.
Thank you. I just wanted to clarify that because there's a lot of doctors.
I think more what I'm saying is that don't throw out other non-surgical therapies as potentially being beneficial, because they are potentially beneficial. Like things that work for some women didn't come from nowhere, and there's actually data that certain therapies are helpful.
Yeah.
You know, seek to improve your quality of life by whatever mechanism you can, because everybody's different, and some patients will respond to different kinds of things, and so it's worth trying different things.
Right.
I think that's an important part of it. Yeah, I mean, part of like find a doctor you trust and trust them. Like, if they're not very experienced with endometriosis, then probably you shouldn't trust them in a way.
What I tell people to ask all the time is ask them how many endometriosis surgeries they perform a year. I think that's a good starting question. And if they say 4, then you probably need to find another doctor.
Right. And also, if they kind of hem and haw about whether or not surgery is going to help you, don't have them do your surgery.
Yeah.
Because the reason why they're hemming and hawing is they don't have a history of success.
Yeah.
Because in their mind, they have not had a history of helping people with their surgeries. And so in their mind, surgery doesn't work.
Well, and most general OBs or GYNs, right, they just do ablation surgery because they don't have the education that they need, correct? Yeah.
Right, exactly.
Yeah.
And, you know, some people do some, you know, really kind of simple excision, really anybody can do. It's not very difficult. But when you get into really complex stuff, it just requires more training than they have.
Sure.
You know, it's very difficult navigating all this. And you have to add it to the sort of baseline that the absolute answers are not known.
Yeah.
You have to kind of work in partnership with a physician who is taking the time to try to think about every case really thoughtfully and what might be helpful here, and try to make the most reasonable and rational path forward to how we can improve quality of life. Nobody's hiding anything from you. Like, nobody's going, oh gosh, I know the answer, but I'm not going to tell you. Like, no, that's not the reality.
Right.
You know, so.
I do want to ask, I forgot I wanted to ask one final question about hormones. So a lot like IVF, IUIs, birth control, if you have pretty decent endometriosis, stage 3 or stage 4, is this risking flaring you up more, increasing, you know, the inflammation, the disease? Should you try to do surgery first and then these either drugs or IVF or IUI? I've heard it multiple ways.
Well, there was one paper recently published that, you know, it's always funny, you know, people put their opinions on a paper and suddenly it's a paper. But there was a paper recently published that claimed to say that IVF did not flare up endometriosis. But my experience has been that in IVF, you're going to have very, very high estrogen levels, and a lot of people are going to have very estrogen sensitive endometriosis. And so I think it's reasonable to think that doing something that's going to make your estrogen levels really high is probably going to flare your endometriosis. And I've certainly seen many women who, you know, seem to get much worse after IVF. Yeah.
Same. At
the same time, if you're trying to get pregnant, it may be the best path forward to get pregnant for a lot of women. And so, you know, it's you're kind of rocking a hard place a little bit. Yeah. I think IVF does tend to make things worse, at least in the short term.
Yeah. I when I talk to people, I tell them if they can maybe have excision first and then do it. I don't know. I don't even know. I'm not a doctor.
Yeah, you know, the data is very controversial
Yeah.
on whether or not, I mean, if the goal is to reduce pain, then yeah, I think it makes sense. If the goal is to do excision to improve the success of the IVF cycle, it's kind of controversial. Like Andrea Vidali, who's a,
Yeah.
kind of fairly well known,
Mm-hmm.
he definitely believes in a positive impact of endometriosis excision surgery on IVF success rates. But like the randomized trial where we take 50 women who are going to have IVF and then another 50, and we do excisional surgery and then go ahead and do IVF, and then we don't do excisional surgery and do the other and do IVF. Like that trial doesn't exist. It probably never will. Now there are a lot of kind of cohort data, which means that you take people that kind of self-randomize themselves, that they're going by whatever path they want to go on, and then you analyze the path of one group of women versus the path of another group of women, and it appears to show that women that have excisional surgery, at least some papers suggest that they have a higher success rate of IVF. But what happens in all academic literature, and it's very frustrating to me, is that everybody has their opinions, and then when they see the paper that says that agrees with their opinion, they go, "Oh, look, here's the paper. Yeah, I was right."
Right.
And then when you see the paper that says you're wrong, they start talking about the methodology of the paper and the study was done wrong, and oh, the methodology was screwed up and all this stuff. And I'm like, in the end, like no one believes anything because they still believe what they believe.
Right.
And they like the papers. They talk about the papers they like, and they don't like the papers they don't like. They say they're methodologically flawed. I've been seeing it for 20 years.
Yeah.
And so for all the wonder that is evidence-based medicine, we can't get past the human psyche that doesn't want to believe a paper.
Yeah.
And so, but at the same time, if you believe every paper, then how come there's 5 papers that say one thing and then 5 papers that say something else?
Right.
And so
it's just a
it's
circle of.
So you got to take evidence-based medicine for what it is. It's not everything.
Yeah. Well, that's really helpful. I appreciate that. Is there anything, I can't thank you enough for all of this information and this time. This is really going to help a lot of people. I really appreciate it. And is there anything you want to add or
90 minutes
do you want to, no, I appreciate it. So we talked about your website. Where else can we find you if people want to find you? Are you on Instagram? Are you on Facebook?
Yeah, I have an Instagram, which I don't put on very often.
I'll link it all.
People want to contact me on Facebook. Nicholas Fogelson, physician, is sort of the one that I'm on the most. There is a Facebook group for Northwest endometriosis and pelvic surgery, but I actually use a professional profile more because, like, if I comment somewhere else, you can't comment as a professional profile. You have to comment as a person.
Yeah.
And then the other thing is that Facebook actually doesn't want to show you pages. They want to show you people.
Mm-hmm.
And so if I write something on my page, Facebook won't show it to you unless I pay them to do it and buy ads.
That's true. Yeah.
And so unless you really engage with my stuff, and then they will say, "Oh, you must want that." In the end, they want to keep you on Facebook. So I mostly use a professional profile. I have so many friend requests, it's like through the roof, and I every now and then go, if you friended me and I didn't approve you, I'm sorry. Like there's hundreds of them, and then there's spammers and bots and stuff, and so I go through it and I call out some and I add some, and so if it looks like there's something in your profile that looks like you may be interested in endometriosis, I'm more likely to say yes than if it's like Nigerian queen who wants to come wants to send me $1 billion. And then I have a website, endometriosis.com.
Okay.
We did a few episodes of a podcast called the Endometriosis Podcast, which is just me blathering on about articles.
I listened to a couple of them. Yes.
Well, there were only a couple.
Yeah.
But
they're good though.
We'd like to do more. We usually just talk about articles. Libby, who I did them with, she recently had a baby, and she runs the Endometriosis website, or she started it, but I think she has other people helping with it now.
Yeah, I like that site.
I think that she has a lot of different areas of interest and responsibilities in her life beyond just that site. So, I mean, people, but I'm always happy to talk to people. You know, people call me from around the country and some people from out of the country, and I'm happy to give you some advice about what's going on with you. I'm certainly happy if someone feels like excisional surgery is what they need. I mean, I can give you some advice over the phone about whether or not it might make sense to do that. And if you want to come and see me, I'm happy to do it. But I'm also happy to tell you one of the many people in the country that I think are good that you may be closer, which is of course destructive to my own business. But again, I'm like more ethical than I should be. So
No, that's a good thing.
so you know, if you call me from New York and you want to go see a really good endometriosis surgeon, it's like, I can tell you 4 or 5 different good people in New York.
Yeah.
And so, and I mean, in Atlanta, I think you went to Center for Endometriosis Care, you know, Ken Sinervo and Jeff Arrington are really good.
Mm-hmm.
And, you know, there's a lot of people that I think are doing good work. You know, in the specific, there's a few specific areas, you know, if you really think you have a neuropalveologically involved thing, I probably can offer some expertise that may not be as replicable in other places. I do thoracic endometriosis cases. I do diaphragm and thoracic cases. I do bowel cases. So there are people that do excisional surgery that don't do those, particularly thoracic. There are very few people that do thoracic cases. The Center for Endometriosis Care probably does more than anywhere else in the country. I may be the next highest, but I don't know. But I've certainly done quite a few of them.
Yeah.
So those kinds of cases of diaphragm work, we know how to do. And I have a multidisciplinary team of a good thoracic surgeon, good colorectal surgeon, good urologist that we do cases together. And so we can do pretty much anything if it seems to be the right thing to do. But it's a fascinating disease. It's fascinating to make a career about. And we just try to hope that we're being of benefit to people. And then the one other plug, I just if you don't mind for a couple minutes. So
please.
I'm involved in research with Juno Biosciences, which is a genetics lab in Salt Lake City, Utah. The CEO of that company is named Ken Ward. He's the most intelligent person I know in my life. He's quadruple boarded in OBGYN and maternal fetal medicine, which is high risk obstetrics. And then he's also a molecular geneticist and a clinical geneticist. And he is really doing really cutting edge research and understanding what is the genetic origins of endometriosis. And I know him pretty well. And so my practice is a consultant practice to that lab. And we gather a lot of samples in order to, like, we genotype all of our patients. Every patient that comes to our practice, we will get your full genome and we'll include it into our database that's helping us to understand what are the genetic origins of endometriosis. We also have a prototyping predictive test that can actually look at your DNA and predict whether or not you have endometriosis. I think that test still needs some work, but it definitely still needs some work. But it's interesting in that we know of about 100 genes that are tightly bound to endometriosis, which means that if you have that gene, you probably have endometriosis. And in doing that test, we can actually identify which genes you have that probably gave you endometriosis, or at least predisposed you to have endometriosis. And so sometimes people have questions about their daughters, about whether or not their daughters are likely to have endometriosis. And if I sequence your DNA and I find out that you have these 3 mutations that are tightly bound to endometriosis, and then we sequence your daughter and she doesn't have them because she happened to get the copies from dad, she probably won't have it because that's probably how you got endo.
Yeah.
And so that is sort of the beginning of the clinically useful information. But I think the longer term clinical information is how we were talking about how endometriosis is a really complicated disease state and not everyone behaves the same. They don't behave the same because they don't have the same genes. And people have different genetic predispositions for endometriosis. And I think that we're going to get to a point where we're going to know who's going to really benefit from surgery. When you have people that are miraculously cured by surgery and you have other people that don't seem to improve as much, like, I think it's not just the surgeon, it's the patient, it's the genetic predispositions and the type of disease they have. And so I think that we may be able to genetically distinguish who is likely to benefit from medical therapy more, who is likely, even like, okay, Lupron is the bugaboo, but the reality is it's on the market because a lot of people have improvement in their endometriosis symptoms from it. The problem is that it causes terrible side effects with some people as well. Yeah. And so probably those people that have long-term side effects are also genetically distinct from the people that didn't. And so we may be able to predict, okay, who is going to be able to take certain drugs and see a lot of benefit and not have bad side effects.
Right.
Like all these things are written in your genes.
That's amazing.
So when you start, like when you don't know people's genetics, you're just flying blind. And we don't know what it means yet, but at least by gathering people's genetics and then tracking their clinical outcomes, we can then start trying to put together the pieces and say, okay, what patterns seem to go with which genes that we know are associated with endometriosis, and then can we predict how different people are going to do, which therapies might be best. And then, I mean, the real holy grail is that will there be a subset of people with endometriosis where we can, infect them with a virus that replaces some piece of their DNA and makes them, cures their endometriosis. And I don't mean cut it out, but literally like fix the genetic defect that led them to have it. And it could be that, you fix that and then their own body cleans it up because it's not continuing to be promoted. It could be that you have to excise it, but it doesn't come back because you've sort of destroyed the mechanism that is creating it. And that's the future that genetic research creates. And that's really interesting to me because I think it's more impactful than going out and excising endometriosis, because A, excision is not the perfect therapy. B, even if it is, it's not scalable. There's not enough surgeons that are good at it. And but if we can understand the disease state better and really come up with some novel therapies that aren't just, we're going to suppress it with progesterone, but really we're going to address the underlying reasons why people have endometriosis, that could be really, really impactful. So
changes the world. I mean, that changes the whole game.
Right. And obviously there's a lot of people kind of rushing for that. I mean, there's obviously, if you could do that, it would be a blockbuster pharmaceutical, guys with money and so there are people that want to do that. And I want to do it because I want patients to have good options, and
feel
so
better,
by contributing all that information to the genetics lab, it's helpful. And then I go back and ask interesting questions that we try to answer. Like somebody had an interesting question of, okay, could endometriosis somehow be triggered by an infectious disease? And it sounds so crazy, but it's not very hard to take endometriosis samples of tissue, sequence all the DNA, and find out whether do we have any viral or bacterial DNA in there, because you can do that. The problem is that's the only way to answer that question. So if you're not doing that, then you never answer the question. But that's not very hard. I mean, if you take a piece of endometriosis tissue and sequence all the DNA in it and ask a computer, do I see any known pathogen in this stuff? It's going to come out with yes or no. And so there's a lot of these kind of interesting questions that, as absurd as they may be, they're easy to answer. And so we can start checking off the boxes and saying, well, we looked at 100 tissue samples and none of them had any bacterial viral signatures. Let's check that off the box. It doesn't seem to be the problem. But instead what you have is sort of speculation about, could it be this, could it be that? And so, I don't know, we're kind of turning the corner into
That's really, I mean, for someone like me who suffered for 20 years, that's very exciting. And now I'll just throw out I have a random hypothesis. A lot of women that I talked to had some sort of like trauma before their endo got really bad. Like I fell rock climbing. And then all of a sudden, like that next year, my endo was every day and really sick. And then I met a girl, she got into a car accident. Then the next year, her endo got really bad. And then I met someone who had a virus, a really bad, I think she had mono or something. And then it was like the next year, her endo was really bad. I was like, I don't know if this is all connected, but this is random how many women have now mentioned this to me. So,
yeah, it's interesting. I don't know how that would be mediated, but I don't discount it. It could be.
No, it just triggered my thought on that when you were talking about virus.
Right. It's just we don't entirely get it. And the more people keep an open mind, the more if you decide you understand it all, then what's there to find out, know? And if we understand it all, then why are we still struggling? So that obviously we don't understand it all.
We don't understand it all. No, that's the truth. Well, thank you again so much. Anything else you want to add?
I don't think so.
Wrap it up. I know we had a long one. Okay. Well, I appreciate it, Dr. Fogelson. Thank you very much.
Great talking to you. Bye-bye.
Bye.